I'm Catherine Porter. I am a senior lecturer at the University of Manchester. So we're going to do a little bit of binocular vision today. If you can fix people's binocular vision problems, then you make them more comfortable, it makes their quality of life better, it causes all sorts of problems. Headaches, you avoid near work, it'll interfere with kids' education. It's a big thing when you fix it. And it's easy to do. You can work through stuff in a step-by-step manner. So we're going to check the prescription, you're going to do a cover test, you look at how people focus, you look at how people converge. If you do those 4 basic things well, that is quite a lot of getting to the bottom of the issue. Obviously, there's lots of other tests that you can do that will help you fully diagnose it, but it's those things that give you a good idea of what's going on. So this kid was sent in because teacher thought that he was possibly dyslexic. As has happened quite a lot, she had given him a yellow overlay. The symptoms that come from visual stress, that can be that you need a pair of glasses or you've got a BV issue. So I'm a big believer in people need an eye exam first. So typical kid, he likes playing with his friends and Minecraft. And when I asked him about what was going on, he couldn't really say whether or not something was definitely double. But he does say that the words were moving on the page and swimming around, and he often loses his place. He said his board is nice and clear in school, but when he's looking at his iPad or books, it'll go blurry after about 20 minutes. And that's preceded by that dull frontal headache. And all of this has been going on for about the last 6 months. I'm going to give you the results that I found for him. The binocular vision is worse than the monocular, and that is a dead giveaway that a kid has got a BV problem. And quite often, if I was measuring reading in a kid, I'd get them to start reading, and then I'd cover one eye to see what they could see. I'd cover the other eye to see what they could see. And then when you take the cover away, if their reading becomes stilted or they hesitate a little bit, you know they've got problems with their fusion. And then the kid, he can't overcome a 20 base out. Quite often in kids, I won't try and do a full prism fusion range, you know, with a bar. If you have a 20 diopter prism and a 10 diopter prism, if you put that up over one eye and then look for the fusional movement in the other eye, that will let you know whether or not they've got good fusion. And actually, he's got a 14 diopter exophoria. So I would be expecting him to be able to overcome at least 28 base out. So what's our diagnosis? Convergence insufficiency. And how are we going to manage him? If you're going to give somebody some exercises for convergence issues, we want people to use 2 pens rather than just one. If I just got somebody to follow this pen in, that shows that their pen can follow, their eyes can follow the pen. That doesn't tell me that you're using your fusion in your head, so you're using the image from each eye. Whereas if you've got 2 pens and you look at the one at the front, the one at the back will always be double. And if it is double, that means I know you're using the input from both eyes. So they've got sensory fusion as well as motor fusion. So if you've got your 2 pens and I'm looking at the one at the front, the one at the back will be double, and then they bring it in. As long as that stays double, they have got fusion. One of the problems with binocular vision is that the symptoms that people complain of, double vision, blurred vision, headaches at the front, words moving, those can be that you just need a pair of specs, or they can be you've got problems converging your eyes or focusing. So I am just listening to people, what people are telling me. So what are they having difficulties with? It depends on what they're doing. So somebody who's maybe a jeweler is working at a very close working distance compared to somebody who's working just on a desktop with it further away. So I'm just going to ask people what their visual difficulties are. Case 2, I just want to know what questions you're going to ask a mum who thinks that her kid's eye is turning in. So these are my answers. What tests are you going to do to differentially diagnose what's going on? K-pictures, yeah? Yeah. Just make sure it's the crowded version. Don't show kids like single letters or single pictures anymore, because uncrowded tests will overinflate your visual acuity. When I left university, the only way we had of checking kids' vision was we had letter matching, and it was like a letter X, and then you'd get them to point at the letter X on the chart, because not all kids will know their letters, so it's like playing Snap. What we didn't really realise at that point in time is that your vision is limited by what's around it, not the size of the letters. It is much easier to read one single letter on its own than if something is squashed in around it. So what do you want to do now? Cyclo, yeah. What drug are you going to use to cyclo the person with? What strength? Ooh, they're 3. It is 1, and I'm really glad you said 0.5. That's not strong enough for a kid this age. They've got so much accommodation that between kind of, it varies, but maybe 9 months, 6 months, 9 months, up to 12 years of age, we should be using 1% cyclo. You've got to be careful because in the very little ones, you don't want to use 1% cyclopentolate because it can cause toxicity problems, and we tend to not want to poison our patients. But certainly from the age of 1 to about the age of 12, you need to be using a stronger strength, so the 1% cyclopentolate. Those kids have got so much focus and ability. If you use the slightly weaker strength, then you're not going to relax all their accommodation and you're not going to get their full prescription. We want to know that kids are definitely +4 or +6. It's relaxing their accommodation that will help turn their eyes out and keep them straight. How do you decide whether or not a child is fully cyclopleged? What do you do? If you look at your ret reflex, if somebody can accommodate when they look from distance to near, the ret reflex will change. If you have completely relaxed somebody's accommodation and they look from distance to your light, the ret reflex doesn't change. And so therefore you know that you're good to have a go at refracting them. Pupil reactions, you will find, especially with cyclo, because it's so strong, their pupil reactions might have gone in like 6 minutes, 7 minutes, but there is no way they are fully cycloed by then. But the child's got an esotropia, so you have to give the full plus. We need to relax the accommodation. If you don't give the full plus, you could end up making them like a partially accommodative, and that will cause all manner of problems. So full plus, yes, okay, it's going to be a bit weird, but they will adapt to it pretty quickly.